Good evening, everyone, and thanks for joining Overcoming Disparity with Novelty in Triple-Negative Breast Cancer, Community Oncology Perspectives on Promoting Equity and Improving Clinical Outcomes. This is presented by Creative Educational Concepts and supported through an independent educational grant from Gilead. Tonight, I have Dr. Rita Nanda of the University of Chicago speaking. Her disclosure can be found on the screen and also in the information I will post in the chat box as we go along this evening. We will be using the polling feature of Zoom, so please answer the questions as they pop up. And if you have any questions throughout the presentation, please also use the Q&A function or the chat bar on your screen as well. So with that, Dr. Nanda, I'll turn it over to you.
Thank you so much, Ashley. So on the agenda for today, for the next hour or so, is to, in the context of new therapies that are now have regulatory approval for the management of triple-negative breast cancer, we want to tackle this concept of, the disparities that we see in the outcomes related to breast cancer. And we'll review a lot of the newer therapies that are now available, immunotherapy, antibody-drug conjugates that are currently available in the clinic, as well as review some emerging data, and we'll review a case of a patient of mine, but in this backdrop of trying to eradicate racial disparities in outcomes. So that's what we're going to be doing. Before we launch into all of that, I'd like to start with just some questions, and we'll revisit these when we're done with the educational lecture. But if I could have you all answer some of these questions, and then we'll assess if we've accomplished our objectives at the end. So we know that Black women have worse outcomes after a diagnosis of breast cancer as compared to white women. What factors contribute to health inequity? Socioeconomic, systemic bias, mistrust of the medical community, comorbidities, or all of the above? It looks like all of you selected all of the above. So now we'll move on to a patient case. This is actually a patient of mine, a 50-year-old Black woman who was diagnosed with a node-positive early stage triple-negative breast cancer. She was treated with neoadjuvant chemotherapy with AC followed by paclitaxel. This was prior to the use of platinum agents and immunotherapy for early stage breast cancer. Unfortunately, she did not achieve a PCR. She had a residual cancer burden of 2, so still had residual disease in her breast and in her axilla after neoadjuvant therapy at the time of surgery. And about a year and a half after she had completed her early stage therapy, she presented with fatigue. We did a routine blood workup. She was found to have some mildly elevated LFTs. That prompted a metastatic workup, which revealed the presence of both a liver and lung lesion. We did a biopsy of her hepatic metastasis that confirmed triple-negative breast cancer. Otherwise, she was feeling well, normal organ and marrow function. She had genetic testing at the time of initial diagnosis that was negative, so no deleterious mutations in BRCA1 or 2. Her recurrent disease was found to be PD-L1 positive. So what treatment would you give this young woman with PD-L1 positive triple-negative breast cancer in that frontline metastatic setting? Atezo plus paclitaxel, carbo or cisplatin, pembrolizumab plus chemo, olaparib, or eribulin? And it looks like a little bit of a mixed bag here. Most of you, about half of you, would give pembro plus chemo, 1 for platinum, a few for atezo plus paclitaxel, and then another a couple voting for olaparib. So we'll revisit some of those questions at the end. And I have one more, actually two more questions for you. So this patient went on to receive carboplatin, gemcitabine, and pembrolizumab in that frontline setting. She had a partial response to therapy, but unfortunately, after 9 months, her disease had progressed in the liver, still maintained adequate organ and marrow function, still somewhat fatigued, has a good performance status with an ECOG of 1. What would you give in the second line metastatic setting? Atezo plus paclitaxel, pembrolizumab plus nab-paclitaxel, talazoparib, capecitabine, or Sassatuzumab govitecan. It looks like, I think, a little bit of a mixed bag here. Looks like most of you, 7 out of 10, would continue on with immunotherapy and switch out the chemotherapy backbone, and then 1 for talazoparib, 1 for capecitabine, and 1 for Sassatuzumab. So we'll come back to those questions at the end. And one last question before we get into our talk for today. So antibody-drug conjugates are newer therapies. These are molecules that consist of a monoclonal antibody that's chemically linked to a toxic payload. Sassatuzumab govitecan is the first antibody-drug conjugate that has been approved for triple-negative breast cancer, and it targets TROP2. What is the toxic payload that's linked to the TROP2 monoclonal antibody in Sassatuzumab? Is it SN38, which is the active metabolite of irinotecan? Is it MMAE, which is a microtubule disruptor, cisplatin, deruxtecan, or none of the above? It looks like sort of a mix here across the board. The majority, about 1/3 of you, voted for deruxtecan, and then second was SN38. So we'll come back to these questions at the end, and hopefully we'll see some movement on some of these answers around a sort of a consistent answer. So on our agenda for the next hour is to review the epidemiology and biology of triple-negative breast cancer. We will review the approved therapies that are now FDA approved for at least subsets of triple-negative breast cancer, including PARP inhibitors, immunotherapy, and antibody-drug conjugates. And then we'll look to the future and some of the emerging therapeutic strategies that are being studied in the clinical setting that may very well make their way to standard of care therapies. Triple-negative breast cancer accounts for about 15% of breast cancer and is defined as a form of breast cancer that lacks estrogen, progesterone, and HER2 receptor expression. It's more commonly found in young women, those under 50, in those individuals of African and Hispanic ancestry, as well as in those individuals who harbor a germline alteration in BRCA1. But to be very clear, triple-negative breast cancer can occur in women of all ages and of any ethnic and racial background. It just has a tendency to occur at a higher frequency in some of these subgroups here. In general, triple-negative breast cancer has been associated with a poor survival. The average median overall survival from the time of diagnosis of stage 4 disease is anywhere from 12 to 18 months. and historically has been a more aggressive form of breast cancer, with about 1/3 of individuals who are diagnosed with early stage breast cancer going on to experience a distant recurrence. And those recurrences are generally visceral recurrences, so in the lungs and the liver. And about half of those who develop stage 4 triple negative breast cancer will ultimately develop brain metastases. Historically, treatment has been limited to chemotherapy, although in the last few years, we've certainly seen a number of newer therapies enter the market. In regards to triple negative breast cancer, again, more common in Black women, Black women are almost twice as likely to develop triple negative breast cancer as white women. And we also know that non-Hispanic Black women are also more likely to have breast cancer under the age of 40 as compared to their white counterparts. So it is absolutely something that we see at a higher incidence rate in Black women. We also know that Black women have a higher likelihood of dying of breast cancer, all forms of breast cancer, but certainly including triple negative breast cancer as well. Black women have a 12% higher 5-year mortality than white women, even after we adjust for age and other clinical factors. But this difference completely goes away when we factor in access to care. So it really tells us that we need to do a better job of offering these novel agents to Black women, making sure that they're getting access to care. And that is a huge part of how we can reduce disparities. So I want you to think about that as we're reviewing all the new data that's emerged over the last few years. We need to make sure that our clinical trials represent diverse populations, and that when these drugs are available, that we're making sure that we're getting them to all patients who are candidates for such strategies. We know that there are a number of factors that contribute to health inequity. I think you all got this answer right on that first question there. We know that there are a combination of different issues that can factor in, and they kind of fall into 4 big buckets. So there are the socioeconomic factors, bias-driven factors. We know that there's a lot of systemic and implicit bias in our healthcare system. And I think we all as healthcare providers should feel really empowered to help break down those barriers for patients. We know there are biological factors, higher rates of comorbidities in our Black and Hispanic patients, as well as higher rates of obesity. And we know that historically there has been a lot of mistrust of the medical community by certain populations, including Black individuals, because of prior bad acts. And we know that Black women are less likely to be offered clinical trials. And we also know that they're less likely to participate in clinical trials. So I think we really need to think about how we can ensure that our trials are representative of the populations that we serve. We know that triple negative breast cancer is not just one disease. We know that breast cancer is not one disease. We've known for quite some time that there are different molecular subtypes, and even within triple negative breast cancer, there are different subtypes, actually 4 distinct subtypes based on expression profiling. So it's important to recognize that not all triple negative breast cancers are going to respond the same. This is work that was done at Vanderbilt University, where they looked at molecular subtypes of triple negative breast cancers, and they found 4 distinct subtypes: basal-like 1, basal-like 2, the mesenchymal-like, and the luminal AR subtypes. And you can see that these different subtypes are associated with different survivals over time, with the basal-like ones being the most chemotherapy sensitive and doing the best, whereas the mesenchymal and luminal AR subtypes have a tendency to be less chemotherapy sensitive and generally don't do as well. Now, there's been a lot of work over the last decade trying to better understand the heterogeneity of triple negative breast cancer. A lot of work has gone into characterizing the genome, the epigenome, the proteome, the transcriptome, as well as the tumor immune microenvironment, understanding how germline alterations in DNA repair genes can impact response. And I would argue that the lessons that we've learned over the last decade have led to some of the major advances we've seen in the management of triple-negative breast cancer over the last few years. So I'd like to shift gears and talk about some of the more recently approved therapies for triple-negative breast cancer that have entered the market, in the last 3 to 4 years now. Now, the vast majority of treatments that we use for the management of advanced cancers, triple-negative or otherwise, are sequential single-agent therapies. We know the anthracyclines, which are frequently used in the early stage setting, taxanes, microtubule inhibitors, are among the most effective therapies that we've got to take care of patients with advanced breast cancer. We now have an approval for the antibody-drug conjugate Sassatuzumab govitecan, specifically for triple-negative breast cancer in the second line and beyond metastatic setting. And we also have available PARP inhibitors for those individuals who have BRCA1 and 2 germline alterations, and immunotherapy for PD-L1 positive advanced triple-negative breast cancer. We do occasionally use combination chemotherapy strategies, although I would say that they haven't necessarily been shown to be more effective than using those same agents sequentially. But in certain instances like impending visceral crisis or bulky disease, absolutely it's not unreasonable to use combination strategies to really try to get that quick response, especially when we think we may not have another opportunity to treat the patient if we don't get their disease under control. There are a number of biomarkers that are predictive of benefit to some of the available targeted therapies. We know that for the PARP inhibitors, olaparib and talazoparib, which are both now FDA approved, in those individuals who have metastatic breast cancer in the context of deleterious germline mutations in BRCA1 and 2. We also know that pembrolizumab plus chemotherapy is approved for PD-L1 positive triple-negative breast cancer, and we'll get to that in the context of this talk. And I think many of you also know that atezolizumab has been withdrawn from the market for triple-negative breast cancer because of no survival advantage associated with the combination and a lack of lack of confirmation of the initial study in a follow-up study. Pembrolizumab also has a tumor type agnostic indication for those tumors that are associated with mismatch repair or have microsatellite instability. I will say that's not very common in breast cancer. It's only about 4% of breast cancers, but certainly something we want to consider and think of when we're doing our next generation sequencing on patients with advanced breast cancer. We can get data from those next generation panels. So we'll start by reviewing the PARP inhibitors, olaparib and talazoparib. Those have both been approved, I believe, since 2017 and 2018. The Olympia trial is the randomized phase 3 trial that led to the approval of olaparib for metastatic breast cancer related to a deleterious mutation in BRCA1 or 2. This was a randomized phase 3 trial where patients were randomized in a 2-to-1 fashion to olaparib or chemotherapy of physician's choice, which included capecitabine, eribulin, or vinorelbine. Again, patients must have had metastatic disease, a deleterious mutation in BRCA1 or 2, and no more than 2 prior chemotherapies for advanced stage disease. The primary endpoint for this trial was progression-free survival with a number of secondary endpoints looking at overall survival, response rate, and health-related quality of life. In the lower left-hand panel, you can see here that this trial met its primary endpoint of demonstrating a significant improvement in median progression-free survival for those patients who were randomized to olaparib. There was an almost 3-month improvement in median progression-free survival. We can also see on the right-hand side here that not only was olaparib more effective than chemotherapy, it was also associated with a better quality of life. So all the more reason to use it when we've got improved efficacy and enhancement in quality of life. The Olympia trial did not demonstrate a significant survival advantage for olaparib versus chemotherapy, at least in the overall intent to treat population. But for those patients who got olaparib as their first line of therapy for metastatic disease. You can see there's a really nice separation of the curve here. Again, this is a subgroup analysis. It's not statistically significant, but you can get a sense that the earlier on in the disease course we use PARP inhibitors, the more likely patients are to benefit and to benefit for quite some time. The Umbraca trial was a very similarly designed clinical trial that looked at the PARP inhibitor talazoparib. So again, enrolling a very similar patient population, those with germline mutations in BRCA1 and 2, metastatic breast cancer. Patients were randomized, in this case, to talazoparib versus chemotherapy of physician's choice, the same 3 chemotherapies that were included in the Olympia trial, but also gemcitabine was an option here. Up here on the upper right-hand panel, you can see that this trial also met its primary endpoint of demonstrating an improvement in progression-free survival for those individuals who received talazoparib, a 4-month improvement over chemotherapy. And also a higher response rate was seen with talazoparib, as well as an improvement in quality of life. So very similar findings to what we saw in the Olympia trial and olaparib we are seeing with Umbraca and talazoparib. The Umbraca trial also did not demonstrate a significant survival advantage for the PARP inhibitor over chemotherapy, but I'd also like to point out that about 1/3 of the patients who participated in this trial subsequently went on to receive a PARP inhibitor outside of the context of this trial. And more than 40% in both arms went on to receive a platinum agent after enrollment in this trial. And both of those factors could have led to the failure or the inability to demonstrate a significant survival advantage for the PARP inhibitor talazoparib over chemotherapy. So again, just to summarize the Olympia trial and the Umbraca trial, both of these trials demonstrated superiority to the PARP inhibitor over chemotherapy, both in terms of demonstrating a significant advantage in progression-free survival, as well as an improvement in quality of life, and a sense that using these agents earlier on in the metastatic course actually may be associated with a further improvement in outcome. I'd like to shift gears now and talk briefly about immunotherapy. The Keynote 355 trial, which I think most of you are familiar with now, is the randomized phase 3 trial, which led to the approvement of pembrolizumab plus chemotherapy for PD-L1 positive advanced triple-negative breast cancer. This was a frontline trial. Patients could not have had prior therapy for advanced stage disease, but could have had therapy in the early stage setting. They just had to have a disease-free interval of at least 6 months from completing either neoadjuvant or adjuvant chemotherapy. Patients were allowed to enroll in this trial regardless of their PD-L1 status, and they were randomized in a 2-to-1 fashion to pembrolizumab plus chemotherapy or placebo plus chemotherapy. The chemotherapy was a physician's choice here and could be nab-paclitaxel, paclitaxel, or the combination of carboplatin and gemcitabine. The primary endpoints of this trial were to look at progression-free survival and overall survival in the overall studied population, as well as in 2 categories of patients with PD-L1 positive disease. Those with a lower level of PD-L1 positivity, defined as a combined positive score of at least 1, and those with a higher degree of PD-L1 positivity with a combined positive score of 10 or more. So to remind you, a combined positive score looks not only at the infiltrating immune cells within the tumor microenvironment, but the tumor cells as well. So this strategy is to look at PD-L1 expression both in the tumor cells as well as the immune cells. And here are the key findings of this trial. This trial demonstrated a significant improvement in progression-free survival on the far right-hand panel here for those individuals who had tumors that had a PD-L1 combined positive score of at least 10. The improvement in median progression-free survival was a little over 4 months. And while there was a trend to improvement in progression-free survival for the overall population, as well as in that subgroup of patients with a lower level of PD-L1 positivity, these did not meet statistical significance. So it really is the 40% of patients who have a combined positive score of at least 10 who are eligible for the combination of pembrolizumab plus chemotherapy. And there was a follow-up presentation that was made at San Antonio this year, looking at all of these different lower degrees of PD-L1 positivity. And it absolutely, the combined positive score between 1 and 9 do no better than the combined positive score of greater than 1. So it truly is that combined positive score of 10 that is the cut point. There is no benefit to adding immunotherapy for a combined positive score of less than 10. We also saw that in these PD-L1 positive patients, response rates are higher. The median duration of response is significantly prolonged. There is a 12-month improvement in the duration of response when pembrolizumab is combined with chemotherapy for PD-L1 positive triple-negative breast cancer. And when you think back to that, one of those first slides where we're talking about overall survival of about 12 to 18 months in this population, this is a really remarkable duration of response. And looking at the different chemotherapy backbones that have been studied, you can see here that regardless of the chemotherapy backbone, it favors the addition of pembrolizumab in these patients. So based on the Keynote 355 trial, pembrolizumab was granted accelerated approval in November of 2020, and then full approval in January of last year. And that was really based on these findings, that there not only was a significant improvement in progression-free survival, but there was also a significant improvement in overall survival of 7 months. So again, really remarkable to see this significant overall survival advantage in these patients. And this is the reason atezolizumab has been withdrawn from the market and should no longer be used for triple-negative breast cancer. The Impassion 130 trial, which is what led to the accelerated approval of atezolizumab plus nab-paclitaxel, demonstrated a significant improvement in median progression-free survival, but no improvement in overall survival. And the confirmatory trial, Impassion 131, which looked at paclitaxel plus atezolizumab, was a negative trial. And so for those reasons, pembrolizumab should be the only immunotherapy which should be used in patients with triple-negative breast cancer. Now, I think all of us likely have a handful of patients here and there who remain on atezolizumab from when it was first approved, and I absolutely do maintain patients on that if they're doing well, tolerating it, and their disease is remaining under control, but I don't start any new patients on atezolizumab-based therapy. Now we'll move on to talk a bit about antibody-drug conjugates. There are a lot of exciting drugs that are in development. So I think this is absolutely where we're heading as a community, not just in breast cancer, but in other forms of cancer as well. Antibody-drug conjugates here are antibodies which target antigens on the surface of cancer cells. This example here is of Sassatuzumab. So this antibody is targeting TROP2, which is the antigen that Sassatuzumab targets, and it is linked to a toxic payload, SN38 in the case of Sassatuzumab. So once the antibody binds to the antigen, it gets internalized into the cancer cell, into these lysosomes. And what happens in the lysosome is that the antibody-drug conjugates degrade such that the antibody is separated from the toxic payload. And that actually allows for that toxic agent to exert its effect and become activated. So as that toxic payload is released from the antibody, it leads to lysis of the lysosome, and then this payload can damage the tumor cell from the inside, leads to apoptosis of the cancer cell. And then in the case of many of the antibody-drug conjugates that are available and in development, this toxic payload can actually diffuse into neighboring cancer cells that may not even express the antigen that was being targeted and lead to apoptosis of other cancer cells within the tumor microenvironment. And that is known as a bystander effect. and can lead to a really potent activity of an antibody drug conjugate, even when all of the tumor cells don't express the antigen being targeted. So Sassatuzumab has a very potent bystander effect. Trastuzumab deruxtecan, which is Enhertu, which is available in the clinic for HER2-positive breast cancer, has a very potent bystander effect. But by contrast, TDM1 or Kadcyla does not have a bystander effect. So there are different mechanisms by which antibody drug conjugates are developed and work in our patients. And so it's important to recognize that there are different mechanisms by which they can work. So here is a cartoon of Sassatuzumab govitecan. So as I'd mentioned, the antibody targets TROP2, which is ubiquitously expressed on the surface of epithelial cells, including all different types of breast cancer, upwards of 90% of triple-negative breast cancers. And it's linked to this toxic payload here, SN38, which is the active metabolite of irinotecan. And the reason we care to think about what is that toxic payload is because it helps us figure out what we need to monitor patients for and what toxicities they may experience. So in the case of Sassatuzumab, because the active metabolite of irinotecan is the toxic payload, most of the side effects that we see are quite similar to what we see with irinotecan. So cytopenias and diarrhea are the two big things we want to watch out for. And as I've already mentioned, Sassatuzumab has a pretty potent bystander effect in that it's stable in the tumor microenvironment and can diffuse into neighboring TROP2 negative cancer cells and lead to apoptosis of those cells as well. Sassatuzumab govitecan was granted accelerated approval, shockingly, on the basis of a phase 1/2 trial. And that is because there was such remarkable efficacy seen in this trial. So this initial trial enrolled 108 patients with heavily pretreated triple-negative breast cancer and was really just looking to see if there was proof of concept and efficacy in these patients. These were heavily pretreated patients who had 3 lines of prior chemotherapy, ranging anywhere from 2 to 10 prior therapies. The majority had had a taxane and or an anthracycline for either early or advanced stage disease, and about 1 in 6 had also been exposed to immunotherapy. You can see here from the waterfall plot that the majority of patients actually had some degree of disease regression. The response rate was 30%, a little over 30%, and almost half of patients had a clinical benefit. So either stabilization of disease, partial response, or a complete response. And on the right-hand panel here on the swimmer's plot, you can see that there was a remarkable duration of response in a subset of patients who did respond to therapy more than a year plus. And I've certainly seen that in my own clinical practice as well, and many of you may have as well. So based on the phase 1/2 trial, Sassatuzumab was granted accelerated approval, but based on the ASCENT randomized phase 3 trial, it was granted full regulatory approval last year. And what ASCENT showed us and the ASCENT trial was a randomized phase 3 trial that randomized patients to Sassatuzumab versus chemotherapy of physician's choice. 4 different options here. Those same 4 options, I think you'll recall from what patients were allowed to be randomized to in the Umbraca trial. And patients were eligible if they'd had at least 2 prior lines of chemotherapy. If patients had therapy in the early stage setting, that counted as a line of therapy. So this trial's actually allowed us to use Sassatuzumab in that second line metastatic setting now. So the accelerated approval was in the 3rd line and beyond setting, but based on ASCENT, Sassatuzumab now has an indication in the 2nd line and beyond setting. So here, patients, again, randomized to Sassatuzumab versus chemotherapy of physician's choice. Primary endpoint was progression-free survival, as well as a secondary endpoint, including overall survival. And this trial was actually halted early based on the remarkable efficacy that was seen. And you can see here, in terms of progression-free survival, there was a 4-month significant improvement in median progression-free survival for those who received Sassatuzumab versus chemotherapy of physician's choice. And even more remarkably, there was a significant improvement in overall survival. And what makes this so remarkable is that the trial wasn't even powered to detect a significant overall survival advantage. So I think it's really important to recognize that in the second line and beyond setting, no other drug has demonstrated a survival advantage. And that is the reason you definitely want to consider this agent earlier on in the disease course. Because I think, as you all know, with triple negative breast cancer, we don't necessarily get another line of therapy. Here, almost a 6-month improvement in overall survival for those individuals who received Sassatuzumab versus chemotherapy. There were a number of subgroup analyses that were done from the ASCENT trial, looking at individuals who were 65 and older versus those under 65, and then also looking at the subgroup of patients who participated in the trial who self-reported as Black. And so we'll just review those data here. These are smaller studies, but I think give us a sense that these groups respond just as well to Sassatuzumab as the overall intent to treat population, and really seem to have pretty similar efficacy. So in those patients who are under 65, you can see here that there was a 5-month, almost 6-month 5-month improvement in overall survival. When we look at those individuals over 65, even more improvement in overall survival with higher response rates with Sassatuzumab as compared to chemotherapy. So absolutely, we should not discriminate by age. Patients do equally as well, whether they're over 65 or under 65. I think one thing we always worry about in our older patients is tolerability. But again, the vast majority of side effects that were seen with Sassatuzumab were grade 1 to 2 and easily managed. Some of the higher grade 3 and 4 toxicities included neutropenia and diarrhea, but both are generally very easy to manage, either with the institution of growth factor or dose reduction. So absolutely, these can be managed in our older patient population. Also, in looking at Sassatuzumab versus chemotherapy, Sassatuzumab was associated with an improvement in quality of life as compared to chemotherapy. This is a little bit of a busy slide, but just wanted to point out that, I think many times we think, is Sassatuzumab more toxic than chemotherapy? Is it as tolerable? But it certainly is tolerable. And again, even though there are toxicities, including diarrhea and neutropenia, it's still associated with a better quality of life, very likely related to the efficacy that we see in that we're able to get better disease control. In looking at the 12% of patients who participated in ASCENT who reported, self-reported Black race, again, looking at the progression-free survival and overall survival, these are really in line with what we saw for the overall intent to treat population, a 3-month improvement in progression-free survival, and then almost 7-month improvement in overall survival. So again, Black patients who participated in ASCENT did just as well as the overall intent to treat population. So I think all the more reason we need to ensure that these newer therapies are making it to all patients who are eligible for such therapies. I'd like to end the last few minutes talking a bit about some of the emerging strategies which are being studied in the context of clinical trials and very well could enter the clinic in the not too distant future. So Datapodomab deruxtecan is another antibody drug conjugate which targets TROP2. So just a similar antibody to Sassatuzumab, but a different toxic payload. So Datapodomab deruxtecan has a deruxtecan payload, which is the same toxic payload we see in trastuzumab deruxtecan or Enhertu. This antibody drug conjugate has a very potent bystander effect, just like Sassatuzumab. And because the toxic payload is different, there are some different toxicities that we need to watch out for with this agent. So the TRopian Tumor O1, pan-tumor O1 trial was a basket trial that enrolled a bunch of different cohorts of patients. And there was a 40-patient cohort that was conducted in triple-negative breast cancer. These are patients with advanced triple-negative breast cancer who'd had a number of prior therapies, and they were treated with Datapodomab deruxtecan or Dato-DXd until they experienced unacceptable toxicity or disease progression. Again, really small numbers, but again, remarkable efficacy seen here with Dato-DXd. You can see from the waterfall plot here, again, this is a small number of patients, only about half of the patients who have participated in the trial to date. You can see here that response rates were 43% with a 95% disease control rate. Really remarkable. I mean, small numbers, but absolutely, this is an effective therapy. And some of these patients here had actually received and progressed on Sassatuzumab prior to enrollment in this trial, suggesting that targeting the same antigen but with a different toxic payload can still be an effective strategy. So I think really exciting to see that we might have another therapy that we can even sequence with Sassatuzumab. And looking here, very early follow-up, but from the spider plot, you can see that patients are remaining on study-based therapy here for at least 3 months. And with a longer follow-up, I have no doubt we'll see longer responses. In terms of the toxicities that we're seeing, again, I think predominantly the side effects that we're seeing with Dato-DXd were grade 1 to 2 toxicities, and they were non-hematologic. There were no cases of diarrhea, and again, very small numbers, but no cases of interstitial lung disease. So I think you all know that deruxtecan can be associated with interstitial lung disease, and we've certainly seen that with trastuzumab deruxtecan, but at least in the context of this small trial, the main toxicities that we're seeing were stomatitis and some nausea, and those were generally low-grade toxicities. Moving on to talk about some of the other antibody drug conjugates that are also in clinical development. Ladiratuzumab vedotin is an antibody drug conjugate that targets LIV1A. LIV1A is expressed in 90% of metastatic breast cancer samples. The toxic payload here is MMAE, which is a microtubule disrupting agent. So when we think about microtubule disrupting agents, we think of neutropenia, neuropathy, hair loss, and that is absolutely what we see with this drug. Again, a phase 1/2 trial of various different dose levels has demonstrated a response rate of about 25%. These are heavily pretreated metastatic triple-negative breast cancer patients. So another antibody drug conjugate that is looking promising in terms of duration of response. Again, you can see a number of these patients are responding for quite some time, 6 months and even beyond. Main toxicities that have been seen: neutropenia, alopecia, neuropathy, some elevated LFTs and nausea. And there are a number of ongoing phase 1/2 trials. And this drug has already been studied in the early stage setting with some promising efficacy there as well. Ladiratuzumab has also been combined with pembrolizumab in a single-arm phase 2 study. And again, you can see here about 90% of patients who participated in this trial had a response to therapy. This was a frontline trial, so I think we certainly need to follow up with some randomized data to determine, is it the ladiratuzumab, is it the pembrolizumab, is there synergy between these two agents? But again, really promising efficacy and a really tolerable combination strategy. The last little bit I'd like to talk about this concept of HER2 low breast cancer. We're all very familiar with HER2 positive breast cancers, defined as either amplification of HER2 using FISH or IHC3+. But we have seen over the years that there's an entity of HER2 low expression. And by that, I mean 1+ or 2+ on IHC, not the zeros. And HER2 low disease incidence varies by hormone receptor status. So about 2/3 of patients who have hormone receptor positive disease have a low level of hormone receptor positive disease have a low level of HER2 expression. And it's about a third of patients with triple negative breast cancer. And the reason there's been a lot of interest about this is because some of these antibody drug conjugates that have been developed for HER2 positive breast cancer have a really potent bystander effect. And so there was a lot of interest in investigating some of these antibody drug conjugates in HER2 low disease to see if maybe some of these patients could benefit from antibody drug conjugates that target HER2 through this bystander effect, which may allow for killing of tumor cells within the tumor microenvironment that don't express HER2. And I think we're going to see some really interesting data at ASCO this year in regards to trastuzumab deruxtecan. So as a reminder, trastuzumab deruxtecan targets HER2. It is the same antibody that is part of trastuzumab. And toxic payload here is deruxtecan, which is a topoisomerase 1 inhibitor. And again, associated with a very potent bystander effect. The toxic payload is stable in the sort of extracellular space. It's able to permeate into surrounding tumor cells and exert apoptosis effects. There was a phase 1b trial of TDXD in HER2 low tumors. And you can see here from the waterfall plot, regardless of HER2 1+ or 2+, you can see that there was really nice response to a number of patients with heavily pretreated advanced breast cancer. And this has been studied both in hormone receptor positive as well as triple negative breast cancers. We will be seeing results from the Destiny Breast 04 study. They've already issued a press release. We know that this is a positive study, and we will be seeing the results at ASCO this year. TDXD has also been combined with immunotherapy. It's been combined with durvalumab in a basket trial. One of the arms of this study looked at durvalumab plus TDXD in HER2 low triple negative breast cancer. This was a 30-patient cohort. And you can see here that there are a number of patients who had a response to therapy. Again, a small cohort of 18 patients, but you can see that 70% of these patients who were evaluable for response had a response to therapy. Now, it's hard to know, was this all the TDXD? Is there synergy between the TDXD and durvalumab, or could it just be the durvalumab in some of these patients? I think you can see that response was seen regardless of PD-L1 status. So PD-L1 negative in dark blue here, PD-L1 positive in light blue. So I think we'll need some randomized data to really understand the benefit of this combination in the future. And we are starting to see a number of randomized trials of antibody drug conjugates with or without immunotherapy. So whether that will replace chemotherapy plus immunotherapy, I think remains to be seen, but certainly a reasonable strategy to investigate. Another HER2-directed antibody drug conjugate, trastuzumab deocarmazine, has also been investigated for HER2 low disease. Again, this is trastuzumab linked to an alkylating agent, in this case, DUBA. And so again, another antibody drug conjugate that may have some efficacy, may make its way to the clinic for HER2 low disease. So trastuzumab deocarmazine has a response rate of 33% in HER2 positive breast cancer. But there were two cohorts that looked at trastuzumab deocarmazine in HER2 low patients, hormone receptor negative, so a triple negative population, as well as a hormone receptor positive population. And you can see that we've got proof of concept here. In the 15 patients who had triple negative breast cancer, there was a 40% response rate, and about a third of 30 patients with hormone receptor positive HER2 low disease had a response to therapy. Now, this drug does have some unique toxicities, and ocular toxicity and fatigue are the two main toxicities that have been seen, but these are generally manageable. I think we'll have to see what happens with this ocular toxicity, because that can certainly impact quality of life. So again, another interesting drug that is being investigated for this HER2 low population. There is also an antibody drug conjugate targeting HER3. This is petritumab deruxtecan. So again, deruxtecan, the same toxic payload as trastuzumab deruxtecan, and this has been investigated in a group of patients with HER3 positive metastatic breast cancer. HER3 expression can be found in a number of different tumor types, including breast cancer, and in a 42 patient cohort of patients with HER3 positive metastatic breast cancer, there was a response rate of just over 40% with a median progression-free survival of 8 months. So again, heavily pretreated patients, really interesting efficacy, again, observed in metastatic breast cancer. And I think we'll have to see, I believe we'll be seeing a larger data set reported at ASCO this year. So just to summarize, there have been a number of new treatment strategies that have gained regulatory approval in the last few years for advanced triple-negative breast cancer. We have PARP inhibitors that are now approved for those individuals with metastatic breast cancer in the setting of a germline mutation in BRCA1 and 2. Immunotherapy is approved for PD-L1 positive triple-negative breast cancer. And just by way of a reminder, pembrolizumab is the therapy that we use now, as atezolizumab has been withdrawn from the market. And we now have Sassatuzumab govitecan, and Sassatuzumab is available to all patients with triple-negative breast cancer. There have been studies trying to correlate TROP2 expression in the tumor with response, but regardless of TROP2 expression, whether it's low levels of expression or higher levels of expression, there's still a favoring of Sassatuzumab over chemotherapy. There are a number of emerging therapies that are demonstrating great promise, a number of different antibody drug conjugates, the Dato-DXd, which is also targeting TROP2 and has shown efficacy even after progression of disease on Sassatuzumab, which to me is really exciting that we might have another agent out there that targets the same population. And then a number of antibody drug conjugates targeting the HER2 low population, as well as HER3 positive metastatic breast cancer. I think we are only learning more and more about triple-negative breast cancer, understanding the heterogeneity that exists within this really complex group of triple-negative breast cancers. And certainly a lot more work needs to be done to identify biomarkers of response and mechanisms of resistance. And I think it's really important just to circle back around to our sort of theme for today in terms of disparities and what we can do to help eradicate those disparities in the clinic. It's really important that as we develop new drugs and enroll to trials, that diverse populations of patients are enrolled to trials that reflect what our makeup is here in the United States. We have a lot of diversity, and we need our trials to reflect that diversity. And it's also very important that all patients, regardless of socioeconomic status, race, access to care, be granted access to these new therapies so that they can also benefit from them. Because much of disparities, while it is multifaceted, does boil down to making sure that all patients have equal access to therapies that can benefit them. So with that, I will just leave you with the summary slide here before we launch back into those pre-test questions again. But this is the landscape of how we take care of metastatic triple-negative breast cancer. This has changed dramatically over the last few years. We now have immunotherapy, so pembrolizumab plus chemotherapy. Remember, you can use carbogem, you can use nab-paclitaxel, you can use paclitaxel, depending on what you think is right for your patient. For PD-L1 positive triple-negative breast cancer, about 40% of patients with metastatic triple-negative breast cancer will have PD-L1 positive disease. If PD-L1 is negative, then obviously chemotherapy should be considered. For those individuals who have germline mutations in BRCA1 or 2, the PARP inhibitors olaparib or talazoparib should be considered. And they should be considered early on in the disease course, as we've seen from our studies that the earlier these drugs are given, the more likely they are to benefit patients for the longest amount of time. Pembrolizumab also has a tumor type agnostic indication for those tumors that are characterized by mismatch repair or microsatellite instability. We have Sassatuzumab now for all patients with triple negative breast cancer. It is approved to be given in the second-line metastatic setting and beyond. I would argue we really do want to use this drug in the second-line setting or as early as possible because it's associated with a survival advantage. And that survival advantage on average was 6 months. And that is much better than we see with other standard chemotherapies. Also, a number of antibody drug conjugates that are showing a lot of promise. Trastuzumab deruxtecan for that HER2 low population, as well as a number of other HER2-directed antibody drug conjugates, which may also demonstrate benefit there. The HER3 antibody drug conjugate, which has remarkable efficacy. I think we need to figure out what proportion of our patients have HER3 positive metastatic disease. And so a number of therapies that are being developed out there in the clinic. And in addition, Dato-DXd, which is another antibody drug conjugate targeting TROP2. So let's head back to our questions. And this is our first question here. So we know that Black women have worse outcomes as compared to white women. What factors contribute to health inequity? And you all had this right from the start, and you have it right again. So certainly a lot of areas where we need to improve in terms of making sure that we can tackle those factors which contribute to health inequity in our patients that we take care of. Our next question, this is a 50-year-old Black woman who was diagnosed with early stage breast cancer. Unfortunately goes on to recur a year and a half after she completes therapy. She has lung and liver mets. It's triple negative. She does not have a mutation in BRCA1 or 2 and is found to have PD-L1 positive breast cancer. So what would you give her in this frontline metastatic setting? Again, PD-L1 positive metastatic triple negative breast cancer. And a great improvement here. Most of you got this right. Pembrolizumab plus chemotherapy would be the best choice. Olaparib would not be a good choice here because this patient does not have a deleterious mutation in BRCA1 or 2. So again, olaparib, talazoparib only indicated in individuals with germline mutations in BRCA1 and 2. There is no efficacy observed in non-mutation carriers. So not something we would want to consider for this patient. So I treated this patient in the context of a clinical trial with carbogem and pembrolizumab. She had a nice response to therapy that lasted about 9 months. She ultimately went on to progress. So now what would you offer her in the second line setting? Again, PD-L1 negative, no germline mutation in BRCA1 or 2, and now she needs second line therapy. Great. So great improvement from our pre-test question. So Sassatuzumab plus govitecan is the right answer. And again, that is because we know that Sassatuzumab in that second line and beyond setting is associated with a survival advantage. Again, not a mutation carrier, so talazoparib would not be a good option for this patient. And, one voted for pembrolizumab plus nab-paclitaxel. So just switching out the chemotherapy backbone and continuing immunotherapy. And we don't really have any data at this point that continuing immunotherapy beyond a line of therapy is an effective strategy, although I certainly think it is worth investigating, but I don't think we have any data there. So really, Sassatuzumab would be the best choice here. Now, we talked about antibody-drug conjugates. These are monoclonal antibodies that target specific antigens that are chemically linked to a toxic payload. Sassatuzumab is an ADC. It targets TROP2. What is the toxic payload linked to Sassatuzumab? Sorry, to the TROP2 monoclonal antibody in Sassatuzumab. And again, this is not to be silly and to think of a question to trip you up here, but the reason we care about the toxic payload is because it helps us monitor for the toxicities that we may see. And so improvement from before. So SN38 is the correct answer. So Sassatuzumab govitecan's active metabolite is, Sassatuzumab govitecan's toxic payload is SN38, the active metabolite of irinotecan. So it is associated with neutropenia, diarrhea. Those are the two big things we want to watch out for. Deruxtecan is the toxic payload of trastuzumab deruxtecan, and the other TROP2 Datapodomab deruxtecan. So there are drugs targeting TROP2 that have that toxic payload, but not this one. So with that, I would like to end and thank you so much for your attention and for participating in the questions. I think I feel really good that we saw an improvement in the answers to the pre-test questions here at the end. I am happy to take any questions if